Welcome and bienvenue to the Age Well Epic Conference 2026. It's a privilege to be here with this community of innovators, researchers, professionals, older adults, and caregivers dedicated to advancing the age tech sector in Canada, and more importantly, to improving the lives of older adults and caregivers through technology and technology-related solutions. My name is Anne Martin Matthews. I am a member of AgeWell's Board of Directors and a professor emeritus in the Department of Sociology at the University of British Columbia. It is my honor to open this exciting event. Now, although we are meeting virtually today, I would like to begin by acknowledging the Indigenous peoples of all the lands we are on today. This acknowledgement reaffirms our commitment to improving relationships between nations and deepening our understanding of local Indigenous peoples and cultures. I encourage you to reflect on the land where you are situated today and your relationship to it and its traditional keepers. The AgeWell office operates on the traditional territories of many Indigenous nations, including the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. We also recognize the current treaty holders, the Mississauga of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis peoples, and is subject to the Dish with One Spoon Wampum Agreement, which promotes peace and cooperation among peoples sharing the Great Lakes region. Here in Vancouver, Canada, I am situated on the traditional and ancestral territory of the Coast Salish people. I am grateful to have the opportunity to work on this land today and acknowledge our accountability and responsibility to further the reconciliation process. AgeWell is committed to fostering an equitable and inclusive practice across all of its programs and explicitly welcomes and strives to incorporate Indigenous ways of knowing and being through our research, education, and implementation programs. AgeWell, Canada's Technology and Aging Network, was launched in 2015 to address a very real need, the need for better solutions to address the challenges of aging well in Canada. AgeWell is a unique Canadian network that brings people together to develop technologies and services for healthy aging. We're also training the next generation of innovators in this field and making Canada a world leader in technologies that help aging populations around the world. The EPIC conference was created to highlight the work of these future leaders and the work they do alongside people with lived experience to ensure that solutions are relevant and accessible in the real world. Older adults, as we know, are a rapidly growing segment of the Canadian population. There are more people over the age of 65 than there are children under age 15. And in fact, population estimates indicate that 1 out of every 4 individuals will be 65 or older by 2030. It's not only that more people are living to old age and later life, but importantly, people are living longer in later life. This is a significant demographic shift, and our health and social services or businesses and products must change to accommodate both the existing and emerging needs of an older population and those that care for them. As a network, AgeWell brings together researchers, students, government, industry, and older adults and caregivers. Together, we create and implement technologies and policies to enhance well-being and quality of life. Since our inception, we have supported over 350 researchers, trained more than 1,500 trainees and research staff, and engaged over 5,000 older adults and caregivers. Our collaborative efforts have led to the creation of over 200 solutions, including technologies, services, and policies, and we support over 70 startups. The EPIC conference, now in its 7th year, was born out of the need to create a virtual and accessible space for our community to share their stories, learn about innovative work, and network globally. Last year, we were proud to host 1,000 delegates from over 15 countries across 6 continents, making it the largest virtual conference in the age tech sector. This year's EPIC conference, running from May 25th to June 4th, offers a unique platform for our community. We're gathered here virtually to share our latest findings, discuss impactful projects, and connect with colleagues from around the world. Our program remains rich and diverse with 9 panels of presentations organized around the 8 Age Well challenge areas, plus a special session on May 29th that celebrates National Accessibility Week with a webinar on improving air travel accessibility for older adults and people living with dementia. We are proud to once again feature Moving the Dial, a segment that brings research to life by showcasing Age Well partners and startups who are translating ideas into practical solutions with real-world impact. I encourage you to explore the EPIC conference webpage for the full program. All conference sessions are free of charge, and we welcome all of you to join the conversation, ask questions, and learn about innovations that could impact your life or the life of someone dear to you. As we come together to collaborate, connect, and foster an inclusive community, we recognize our shared responsibility to create a welcoming environment for all. We value the participation of each community member and strive to deliver an enjoyable and fulfilling experience. All participants are expected to conduct themselves with integrity, courtesy, and respect, observing our code of conduct available on the conference website. I would like to extend my sincere thanks to the organizers, our Age Well partners, and especially to the stakeholders, students, postdoctoral fellows, research staff, and early career researchers who will be sharing their work with us. Your contributions are vital to the success and future of age tech in Canada. Thank you, and let's have a fantastic conference. Without further ado, let's get this EPIC conference started. Caitlin McArthur, Associate Professor at Dalhousie University and Affiliate Scientist at the Maritime Sport Unit and Nova Scotia Health, is here to chair the Supportive Homes and Community session. Caitlin, over to you.
Thank you so much, Anne. I'm really excited to be here today, and thank you for that epic opening. As was mentioned, my name is Caitlin McArthur. I'm an associate professor at Dalhousie, and I'm going to be chairing this first session, Supportive Homes and Communities. So before we begin today's session, I'd just like to note a few things. The 9 EPIC conference sessions will take place on Zoom from 12 to 1 p.m. Eastern Time from Monday to Friday, ending on June 4th. We encourage you to attend all of the sessions. Check out the Age Well EPIC conference webpage to download the EPIC conference program, which includes details on each challenge area session. We will begin today's session with a short presentation by me on the Supportive Homes and Communities challenge area. And then we'll enjoy 2 research presentations with a 5-minute Q&A following each presenter, followed by a Moving the Dial presentation featuring a supported startup or a program. And finally, we'll close the session with a general Q&A. I'm excited to introduce today's EPIC conference presenters. So we have Shua Kim and Stefanie Tan, who will present Beyond Reactive Care, Developing a Wandering Risk Assessment Prototype for Home-Based Dementia. The next presentation will be Chi-Ling Joanna Sin and Carol Lee, who will present Aging on the Margins, Technology-Enabled Supports in Multi-Tenant Housing. And finally, Alex Chi will highlight how PontoSense is moving the dial by improving quality of life for Canada's older adults and caregivers. All attendees are encouraged to use the Q&A box to ask questions, leave a comment on a question, and upvote questions that others have submitted. We also welcome you to use the chat. The session is being recorded and will be available for playback. Links to playback will be posted on the EPIC conference webpage and the Age Well YouTube channel. Should you choose, you can enable closed captioning for Zoom on the Zoom toolbar. Without further ado, let's begin with an introduction to the challenge area. Let me just get things shared and we can jump right in. All right, so our challenge area today is supportive homes and communities. So just to kind of bring us all together about why we're here with this particular session today, first, let's talk about the problem area that we're trying to address. And the main thing, as was mentioned in the introduction, is that our aging population is increasing. And many older adults live with chronic health conditions that can impact their ability to do daily activities like socializing, taking part in leisure activities, self-care, and household tasks. And ongoing challenges that older adults may experience with these activities may adversely affect their well-being themselves as the older adults, but also their caregivers and care partners that they live with or who are supporting them. So one possible solution, and what we're here to hear about today, is age tech and how age tech can help support this. So age tech can help support older adults to age in a place of their choosing. So I say in a place of their choosing because I think there are many places that we can choose to age. And this can help support a variety of age tech can help support people to age in place by a variety of different ways. So it can help support connectedness, it can reduce isolation, it can increase independence among older adults, it can also help decrease stress for caregivers and care partners, maybe prevent transitions that aren't necessary. So moving from home to the hospital to a long-term care home, or home to a long-term care home, or whatever transition is that is unwanted and potentially unnecessary. It can also help improve health and well-being and enable people to live well with advanced frailty, ill health, or other risk factors that increase their risk for things like transitions or for poor health. And creating age-friendly communities and social infrastructure. So a lot of things I talked about were more at the individual level, but I think also age tech has a huge role to play in connecting people together and reducing that social isolation. So just a few examples, some of these I've been involved with my research, either as a primary investigator or as a co-investigator. I think there's a variety of different ways that age tech can help people stay in the place of their choosing. So first, thinking about safety and fall prevention. As a physiotherapist, fall prevention is often at the top of my mind. So things like smart lighting, changing the environment, voice assistance, or even fall detection wearables, so that if somebody does fall, we're able to get them help if they're on their own and they're unable to get up by themselves. Next piece is thinking about health and medication management. So looking at things like smart pill dispensers, as well as remote patient monitoring, which is becoming more and more popular. Then we can think about the home itself, so home monitoring and security. So thinking about non-intrusive motion sensors or using things that decrease the risk of privacy breaches like infrared technology to understand how people are moving, or if they haven't been moving in a while, what the issue might be. But also things like as simple as a video doorbell or smart locks. And then if we're thinking about kind of more communal living, things like automated entry to ensure safety. And the last piece we can think about is comfort and convenience. So things like smart thermostats. This is really, really important in our current climate, physical environment climate, where there's a lot more heat emergencies lately than there have been in the past. So thinking about keeping people at a good temperature that is safe is really important. And also things like smart plugs, so that we can turn things on and off remotely or on a timer or any of those types of things. So these are just a few examples of some of the ways that age tech can help people age in a place of their choosing. So next up, that's our challenge area that we're going to be talking about. So now I'm going to turn things over to our presenters. So presentation number 1, we'll start with Shua Kim and Stefanie Tan. So just to give an introduction to our speakers, Dr. Stefanie Tan is VP Research at MedicAlert Foundation Canada, where she leads the organization's research and innovation function. leveraging data and building evidence for MedicAlert's mission and impact. An internationally trained physician with a background in clinical medicine and public health, she is passionate about translating research into real-world solutions that protect vulnerable populations. Her current work focuses on dementia safety and wandering prevention, health technology assessment and adoption among older adults with dementia, and industry research collaborations, for example, with the University of Toronto's Translational Research Program, bridging academic research and real-world implementation. Our second presenter is Shua Kim, who is a Master of Health Science candidate in the Translational Research Program at the University of Toronto, with a professional and research focus on aging, dementia care, and long-term care systems. Her work centers on bridging the gap between evidence and practice, informed by experience in quality improvement and community-based health. She is particularly interested in translating research into practical, scalable approaches that strengthen care delivery and improve outcomes and quality of life for older adults. Shua's interests include advancing person-centered care and supporting system-level changes that better respond to the needs of Canada's aging population. So without further ado, I'll ask you to share your screens and take over the presentation.
Thank you so much, Caitlin. I hope everyone can see the screen. Okay, wonderful. So we'll get started. Hello, everyone. I'm Shua, and as Caitlin introduced me, I'm a master's student at the University of Toronto's Translational Research Program, and I'm joined today by Dr. Stefanie Tan, who is the Vice President of Research at the MedicAlert Foundation Canada. And as an AgeWell trainee, I've been working with Dr. Tan and a team of graduate researchers on an early stage project on a caregiver-facing wandering risk assessment framework. And today we're really honored and excited to share where we are at so far.
So wandering is one of the most serious risks associated with dementia. An estimated 60% of persons with dementia in Canada will go missing at least once during their journey with this disease. And these incidents can lead to injury, hospitalization, and death. They place enormous strain on caregivers, and they are largely preventable with earlier action. Most dementia care in Canada happens at home. Family caregivers are often the first to notice changes, including increased restlessness, attempts to leave, and growing disorientation. They are observing the early warning signs every day, but that knowledge is not being captured or acted on proactively. Risk identification in the current system happens after an incident or after a caregiver raises concerns at a clinical visit. There is no standardized, proactive framework for wandering risk in Canadian home care. And a quote from one of our stakeholder interviews anchored this project in the current reality, which is that people get lost, they get hurt. And that's just what happens. But no, it doesn't have to be that way. At MedicAlert, we hold data on over 25,000 registrants and run the Safe and Found program, Canada's national wandering registry, for families navigating these exact situations, which means we know what the gaps look like from the inside. And that's not organizational context. That's why this research question matters and why it belongs in partnership with an organization that sees the consequences firsthand. So we started with a specific question. How do we turn what caregivers already observe every day in the home into something both caregivers and clinicians can actually act on together? The goal was to develop an evidence-informed, caregiver-facing wandering risk assessment prototype for home care that helps caregivers recognize early signs of risk, structure their observations, and support more proactive conversations with clinicians. Not a tool that replaces clinical judgment, but the structure that makes caregiver knowledge clinically actionable.
So our approach had 3 phases: an environmental scan of the literature and existing tools. We also had stakeholder engagement, over 10 semi-structured interviews with clinicians, researchers, caregivers, and different advocates from community organizations. And we also led iterative prototype development, which is also ongoing, where we built a draft framework and ran an initial sensitivity testing survey. And a small note on the scope is that our project started as a graduate research project with a defined academic timeline, so that really shaped how far we could get in terms of stakeholder reach and validation. So what we're presenting today is obviously a continuing work, but across these interviews, clinicians and caregivers that we spoke to really kept telling us that the knowledge was already there, kind of sitting with the family or with the informal caregivers. And but what's really missing is a way of structuring and surfacing that. And the caregivers described having weeks of observations in their heads that are relevant to wandering in the loved ones that they care for, but there was no way to organize or communicate them at a clinical visit. And that's really what shifted our design from initially being a clinician-facing screening tool to a caregiver-facing communication bridge. And so the core output is, as you see here, it's a multi-dimensional risk prototype or framework that's organized across 8 evidence-based domains, each with associated subdomains that are also being developed. And these domains were developed through a combination of literature review, existing validated instruments, including the Dalhousie wandering scale and the risk of wandering scale, and more, as well as stakeholder consultation to fill in any gaps. And together they capture a more comprehensive range of factors that contribute to wandering risk than other validated instruments that we've seen. And so the first domain we identified was dementia and cognitive risk factors. So essentially how advanced the dementia is, what type, and whether the person's aware of their own kind of cognitive decline. And so reduced insight and advancement of dementia in a person is happens to be one of the strongest independent drivers of possibly going missing through wandering. Domain 2 was functional and mobility capacity, where whether the person can still manage daily tasks, navigate familiar spaces, use a phone or GPS to navigate or to possibly reach somebody else for help. And so someone who is physically capable but cognitively impaired, can travel far before anybody else notices. So this domain was also important. Domain 3 was wandering phenotype, including the history, frequency, severity, and pattern of past wandering events. So prior wandering is the single strongest predictor of future wandering risk. And domain 4 was behavioral and psychological contributors like anxiety or unmet needs like pain or boredom, environmental triggers. And so wandering is often a response to something the person is not able to communicate verbally. And domain 5 is medical and medication risk, so chronic conditions, recent illness, medications that sedate, disinhibit, or cloud cognition. So even a stable person's risk can actually spike acutely from this. And domain 6 was environmental risk. So what's near the home, like are there busy roads, water, unfamiliar terrain? And this captures not just whether an exit actually would happen, but how dangerous it is when it does. And domain 7 is supervision and care context. So who's watching, how often, and is there any kind of caregiver burnout as well? So caregiver burden can actually be both a risk factor and a barrier to acting on that and managing that wandering risk. And lastly, our domain 8 is protective and monitoring factors such as GPS devices, door alarms, redirection strategies, and safe return program kind of enrollment or registries. And so an important thing to note here is that there isn't a single domain that really forms a person's unique wandering risk profile. Rather, the risk emerges from the interaction across all of these 8 and possibly even more, which is why it needs to be examined more holistically. And so for us, this domain framework as it stands is kind of the most developed output of our project. And so alongside that, we're beginning to explore a provisional 2-part prototype system as a future direction. The first component is a caregiver-facing guide to help organize the observations across 8 domains and bring a more structured summary into clinical conversations. And the second is a clinical clinician interpretation guide to help care providers review caregiver input and considering kind of possible next steps, although we're not doing any clinical decision making for them. And so together, the idea was to raise awareness on both parties and to also create a bridge between caregiver observations and clinical decision making. It's not, once again, a replacement for clinical judgment, but really a structure to support more informed conversations.
And from MedicAlert's perspective, our Safe and Found program already has these intake conversations with families at the point of registration. And that is exactly where a caregiver-facing tool like this belongs. We're not waiting for a fully validated instrument to think about where it fits. We know where it fits from our perspective. The question is getting it to the standard where we can deploy this responsibly.
And as a quick note, across both the literature and stakeholder interviews, we found that there isn't sufficient evidence base to support differential weighing of domains. So, and we know that wandering risk is nonlinear, individualized, and also context dependent. It's very unique for each person. So a score really implies a precision that the evidence doesn't yet support and could actually mislead clinical decision making. So we opted out of that. And instead, we're going for a structured observational summary that really surfaces what the caregiver knows in a format that the clinician can help act on while keeping that interpretive judgment where it belongs. And so we ran a small pilot sensitivity testing survey with 3 clinicians, researchers, and dementia care specialists. And the domain structure was perceived as relevant and comprehensive. And there were different risk tiers that we initially introduced that were considered meaningful for decision making. And a digital format for a potential questionnaire that includes these domains was strongly preferred. And there were tailored intervention outputs that were rated as highly valuable, and a domain importance hierarchy kind of emerged when we asked which ones are the most kind of significant for wandering risk, and we found cognitive factors, wandering history, and functional capacity that were rated the highest. And to be transparent, obviously 3 respondents is a small pilot, but this was this had a defined timeline, and it is a continuing work that we're doing. So this pilot really just essentially confirmed the direction that we're going. It didn't yet establish validity, and expanded testing is our next step. So it's already underway through our continued engagement with MedicAlert and also the broader stakeholder community.
So the shift this work enables is from reactive to proactive. For caregivers, it structures what they're already observing into something clinically meaningful, giving them a way to start the conversation earlier, before anything goes wrong. For clinicians, it standardizes risk identification and reduces reliance on incident-driven assessment. For the system, it fills a gap that no equivalent framework currently addresses in Canadian home care. Our next steps include expanded stakeholder engagement, prototype refinement, and implementation pathway development through community programs and national dementia networks. Safe and Found and the National Wandering Registry are natural channels for distribution and validation. We have the infrastructure to take this from prototype to real-world pilot.
Thank you so much. And if you take one thing away from our presentation, it's that wandering risk in dementia has possibly fatal consequences, but it's still largely managed reactively in Canada. And caregivers see the signs every day. But what they might need is a structure to raise awareness that there is a wandering risk at all, and to surface what they already know as well. And that's what we're building at the moment. So if this happens to resonate with your work, please reach out to us. And thank you so much for listening. We're happy to take your questions.
Okay, thank you so much for the presentation. That was very, very interesting. So we do have one question, 2 questions from one person in the chat to get us started. So the first question is, how, according to your opinion, authorities can support reduction of burnout among caregivers in persons with dementia?
Stefanie, do you want to go ahead, or I can tackle that too?
Sure. I think it's really going back to the framework and building out those conversations and going into the root cause of what is that cause of burnout, because these conversations or the framework that Shua and her team have been looking into will really surface what's the root cause of burnout.
Yeah,
Great.
and we want to say that there's obviously we had the two provisional kind of guides for caregivers and clinicians. One of the reasons why we wanted to develop a reference guide or something that helps clinicians understand is because we wanted there to be somewhat of a two-way communication because we know that obviously yes, caregivers are going to they're going to be able to provide that knowledge about some of that wandering risk and once it's structured it can be gold, but we know that a lot of caregivers have a lot of things to do and they experience that burden and possibly even burnout. And so it's not something that they're always aware of. And what we heard is that often there is more of a focus on the actual cognitive decline that is happening. And that can be very personal to the caregiver as well as they see that. Whereas wandering risk might kind of be a second thought. Yeah. So hopefully we're going to raise awareness as we pursue this project as well.
Fabulous. Thank you. So second question, uh, how, according to your opinion, can we encourage proactive caregiving and not reactive? These questions are from Schmel. I believe that's how you say that. So I guess how can we be more proactive and less reactive? And hopefully your algorithm will do that for your framework.
Yeah, I think, I mean, we have considered collaborating with the likes of the Alzheimer's societies and other organizations that caregivers will have access to, or that they might actually reach out initially when they start seeing certain issues. And we know that not every caregiver is going to go to a clinician right off the bat for the things that they're concerned about, because there might be many things. And so it's just, I think, developing some of those different touch points to help raise awareness. And I know that like our project is one, but we also just generally want to raise awareness of the consequences of wandering, how dangerous that can be, and how we can actually help manage that because it's a very distressing thing to think about managing just perhaps by yourself as a caregiver. Yeah, I hope that answers your question, Shua.
Hey, the next question is from a policymaker perspective. What can policymakers and government do to reduce wandering risk?
I think from that perspective, it's the awareness about what are the impacts of critical wandering and what are the downstream effects of it, and how can we mitigate this through proactive risk management? Because there's so much we can do to mitigate this or to eliminate the consequences, which are life-threatening.
Great, thank you. What do you think is the next step in their care once these conversations happen between the caregivers and providers? For example, what changes do you foresee happening as a result of the framework?
Yeah, that's a great question. We obviously, because we're developing the framework at the moment, we haven't been able to develop so many outputs for it yet. But depending on what our stakeholders share, as well as in terms of what is most useful for the majority of caregivers in Canada, perhaps like we can have something like a digital output that perhaps makes recommendations for what next to do, or what are some areas that, oh, maybe you should focus on mitigating or managing. And also, just the thought for me is that we don't want to pursue this project and kind of increase the paranoia of caregivers. We want to help them feel comfortable that, hey, like there are these resources out there. So I think different community connections and having a resource hub might be very important. We know that those kinds of pages already do exist. So maybe making those a little bit more popular in some way. And also just having connections with clinicians and you know, we want more primary care providers to be aware as well. So.
And I think if I could add to that, it will just improve care coordination overall for individuals and the families who are trying to manage the risks of wandering.
Great. Okay, we'll do one more question. Have you looked into proactively identifying fall risk or wandering risk through passive means like computer vision through cameras?
That's a very interesting question, Pascal. We haven't looked into that yet. We think that currently it's kind of in a separate domain, in that we're trying to map out some of the risk factors and help caregivers recognize, whereas I think this might be kind of an intervention, which could come down the line, maybe down the stream, where we could introduce some of these interventions or possibilities to caregivers or clinicians. That would be a very interesting next step. Yeah.
Fabulous. All right, we're going to have to pause the Q&A there for now, but we'll save these questions for our general Q&A at the end of our session. So thank you so much, Shua and Stefanie. We're going to shift over to our second presentation with Chi-Ling Joanneson and Carol Lee. So Chi-Ling Joanneson is a research scientist with St. Joseph's Health System Center for Integrated Care. Dr. Sin is a health services epidemiologist and program evaluator. Her current research focuses on housing for people with support needs and disadvantaged by system barriers. Carol Lee is the manager of the Rooming House Project at Dixon Hall. She has been working in the social services sector for over 20 years and has a passion serving vulnerable populations. Her current role is managing a diverse team of workers supporting people living in rooming houses owned by Toronto Community Housing. All right, so if you want to go ahead and share your screen and start your presentation. Thanks so much.
Hello. Hi, I just can't disable my video. I'm not sure. It's saying it won't. It's disabled. Hi, everyone.
That's okay, we can still hear you.
Okay, that's great. Hi, everyone. My name's Carol Lee, and I'm here to talk a little bit about the Rooming House Project, and Joanna will share a little bit more about our research that we did together. So, rooming houses, once considered a temporary place to reside or a short-term stay, has now become a fixture in the realm of permanent housing. In the 1950s, the post-war boom started to increase wages for the middle class, which increased home ownership, and rooming houses were left for the downtrodden. Despite deteriorating rooming house stock, licensing was limited, illegal, and led to many dying in rooming house fires between 1970s and 2000. So in 1995, rooming houses were licensed in the city of Toronto, but not in the GTA. So it was still illegal, like in Scarborough, Brampton, Mississauga, and I guess Peel, all the surrounding areas of GTA was still illegal. But in 2024, all rooming houses became legal and were licensed under municipal standards. And these are just a picture of some of the rooming houses that we support, that Dixon Hall supports. All right, the next slide. Oh, do I? Great. So a rooming house is congregate housing where there are four rooms or more in a house. So each person has their own room and share the bathroom and kitchen with other housemates. Toronto community housing rooming houses don't have any common areas or laundry. There's also private rooming houses as well, but many of which are unlicensed. But like I said, in 2024, these licenses were changed, but many still were shut down just to the rising costs that it just took to make these rooming houses licensed, right? The cost was quite high, so many of them did shut down. And from our literature, we do know that people who have a history of precarious housing and unmet basic needs often experience premature aging and death. So the next slide, I'm going to be describing a little bit about what it's like to live in a rooming house, and there are many, many challenges. Like I said, these were supposed to be temporary stays. So just sharing a bathroom, I think the most that have to share a bathroom are 6 to 1 bathroom, which is quite a lot still. They also have shared kitchens where there's no furniture furnished. People will sometimes bring in furniture, but oftentimes it gets destroyed or taken. People also have to deal with a lot of pest issues from mice to bed bugs, and sometimes there's a lot of delayed maintenance as well. So people have to live within those sort of environments for a long time, and sometimes even heat can be an issue too, where they don't get heat for a few days just because maintenance is so slow. And then there's also generally a lack of cleanliness. Like Caitlin was saying earlier, folks are aging, so just regular household tasks have just become very, very challenging for people. I think some of them even have to go up to the highest stairs, which is like the third floor. So it's really challenging just even getting up and down the stairs because there's no elevators. Some of the stressful living conditions that people have to deal with are with theft, noises at all hours of the night. So if somebody is actually trying to work, getting sleep can be very challenging, and even using the bathroom and kitchen can be very challenging because sometimes people also have guests that come in, that and tend to monopolize some of these common areas as well. A lot of our folks are poor, so many of them are on fixed social assistance, so they have very limited income. So luckily, we're able to provide some of their basic needs and programming for them. We're starting to see some more newcomers coming into these spaces. So most of them have different needs and are busier with work and school. We're also seeing health and aging challenges. So folks are really socially isolated, and unfortunately, a lot of their health issues some of them just don't want to go, even though we really want to encourage our folks to go to the hospital or get a doctor. It's very, very really challenging because they just don't want to. So some of their health needs really increase, and then they have to go to the hospital. Which is unfortunate. There's also a lack of housing for seniors, especially for those who are using substances. There just are no places for them. So a lot of our folks, that have been here, I think they've been living there for like 20 years, a few of them, and so they're quite old. They're in their 80s living in these rooming houses. There's also a lack of social relationships because a lot of them are socially isolated, and the fact that they have no phones or technology makes it even more challenging. And a lot of them don't have family. There's also a lot of stigma for them. There's a lot of lack of understanding, compassion, um, where people are just like, get a job kind of idea. And then we also dealing with fragmented systems where the social safety net is crumbling and is deteriorating and not supporting people as they used to, as well as I think, impacts of technology as well. A lot of our folks are not able to keep up with the impacts of technology with no phones or access to anything like that in terms of technology. So, therefore, in 2018, the Rooming House Project was created to support tenants living in the Rooming House Project owned by Toronto Community Housing. So the goal was really for people to get connected to their own homes, as well as to try to connect them within their own, the neighborhood within their own homes, and then also connecting them to the larger community. So tenants that we serve are mainly older men living with mental health and substance use issues. They have chronic illness. Substance use seems to be on the rise as well. We're seeing more seniors using. And we have a team of housing. So the team provides housing stabilization, community and basic need support, harm reduction, pest control, and peer support. And most recently, Dixon Hall has also purchased a few of Toronto Community Housing properties, or are entering into sort of the supportive housing realm. And this has also been enriched by partnering with McMaster Institute on Research and Aging, in a research project that we did together, which Joanna will talk a little bit more about. And I'll turn it over to her. Thank you.
Thank you, Carol. So like Carol said, with the current program running since 2018 and expansion now underway, we engaged in a research project to make the most of this opportunity to reflect on the program's current state and identify future directions. Our project was made of 2 phases. First, we conducted interviews and focus groups with Rooming House Project staff and clients to understand the program's goals, gaps, and opportunities. Based on these consultations, we collaboratively decided to focus on staff mental health. And then in the second phase, we conducted a rapid scoping review and did interviews with peer organizations serving similar populations. Key guiding principles of the project included co-leadership and lived experience, so we made a deliberate effort to engage people throughout the process. This included holding 2 town halls, presenting at a staff meeting, and having regular planning meetings with Carol. The town halls became one of the most meaningful parts of our project. Carol played a huge part in encouraging staff and clients to attend. We had about 20 to 25 people attend each of the town halls. Each followed a simple structure where we brought lunch, we had a short presentation, and then moved into small group discussions. In our final town hall, we also used a dot voting exercise to prioritize next steps. So onto our findings. For this presentation, we selected 3 themes to highlight the role of technology-enabled supports. And as Caitlin showed in her beginning slide around the age tech examples, you see many of this recurring same examples around safety and home monitoring. And so the findings I'm presenting here are showing very similar themes, but with maybe more of a lens towards people living in rooming houses. So the first theme relates to safety and security, which is a very important issue that you heard from Carol about rooming houses. So tenants described experiences of theft, hearing noises at night, substance use in common areas, unwanted guest traffic, including people who come in to sell drugs or sleep in the stairwells. So some tenants told us they would feel safer with security cameras in the buildings. In the past, staff also used harm reduction technologies such as overdose detection apps and a safer use phone line as tools that could help during crisis events. The second theme relates to digital exclusion. Many tenants, as you heard, don't have phones, computers, internet, or digital literacy supports. In practice, this means that barriers to using technology become barriers to accessing essential services, whether that's connecting to their doctor, social worker, or employment opportunities. And then the third theme encompasses opportunities for staff supports. Staff talk to us about the heavy emotional toll of supporting clients living in poverty and distress. Staff often go above and beyond, but this places them at risk of feeling overextended and unsupported, especially when they're dealing with fragmented systems and limited resources. So we see strong potential for information and communication technologies to support staff through more accessible training, peer connection, and real-time guidance. In terms of next steps, we are very excited to look for the future. So from her perspective as the manager of the Rooming House project, Carol has already implemented a lot of ideas that we heard from staff and clients, and she hopes in particular to continue expanding the peer worker program. On the research side, we see lots of opportunity to build on what we learned through the Knowledge Synthesis Grant and explore innovative ways that Dixon Hall can continue to support staff well-being. So as a final takeaway, Carol and I just wanted to share a reflection about what made this research project meaningful to us. So it was important to us that the project was led by community priorities. It was important that we engaged people within the communities, which recognizes that not everyone has the same perspective. And finally, while it wasn't within our current project, within the scope, we are driven to make changes in the broader systems and structures that shape housing, health, and well-being in our communities. And it's this vision that keeps us on track to do work that we know is not only academically productive, but also the most likely to create positive change. So thank you very much, everyone, for the opportunity to share today.
Hey, thanks for the presentation. It was really interesting to hear about the work that you're doing. So I'll ask the audience if they have any questions. You can place them in the chat box. Maybe while we're waiting for a question to come in, sorry, in the Q&A box, not the chat box. While we're waiting for questions to come in, I was wondering, what's the next step? Do you have another research project in mind, or what's kind of the next thing that you're going to undertake? And how is Age Tech involved in that?
Yeah, great question, Caitlin. So I gave a very quick, because I knew we were short on time, around next steps. So we're really hopeful to be able to continue doing research with Dixon Hall. The partnership between the McMaster Institute for Research on Aging, MIRA, and Dixon Hall Center is just a great opportunity to bring applied research to achieve the aims of Dixon Hall in terms of addressing poverty, addressing social injustice, and so on. And so what we're hoping to do is build on our existing findings around staff mental health. So that last box that you saw around staff supports, we've learned a lot about peer support technologies, ways to get access to like on-demand sort of clinical advice that we can sort of tap on. So we want to build a future proposal, hopefully, that we can continue exploring that with Dixon Hall.
Fabulous.
I was just going to say it's also really nice to put like so the research pieces and with the practical pieces together, right? So it's been a really great opportunity to do this. So I'm really hoping that we can actually put this research into action though at Dixon Hall. So it's going in that direction. So very grateful for that.
That's great. It's always great to see when research, makes a difference and is applied immediately. One question that came in the chat box is the project geared towards older adults or adults in general?
I'd say yes. I mean, we are working with adults, but I would say that people who are in this sort of homelessness sort of sector, we kind of consider seniors at 55 and up, just because of all the different, conditions and things that they've had to live through. So, but yeah, so they are adults, but I would say the majority of them are definitely over 55.
Great, thank you. Okay, I think we're gonna, for the sake of time, move along to our next presentation. Thank you so much, Carol and Chiling Joanna Sin. So our last presentation is the Move the Dial presenter, Alex Chi for PontoSense. So Alex Chi is the CEO of PontoSense, a Toronto-based company building privacy-first sensing technology that helps older adults live safely and independently at home. PontoSense uses wireless AI sensing to understand movement, wellness, and vital signs without cameras or wearables. The company works with care providers, healthcare systems, and telecom partners to scale aging-in-place solutions across North America and globally. Alex focuses on bringing practical innovation to aging and care, helping families gain peace of mind while supporting independence at home. So Alex, I'll turn it over to you for your presentation, and we'll come back together for a Q&A afterwards.
Yeah, thanks, Caitlin. Hi, everybody. Thanks for having me today. Looking forward to sharing a little bit more about what we do. I will say that, just hearing the other presentations, I think some of them have covered some of the points that I'll cover here. But what my objective is to kind of share a little bit about what we're doing at PontoSense, but also maybe more importantly, share some like interesting facts, right? Because I think we all want to take away some learnings from every one of these webinars. But Caitlin did a good job introducing the company. So PontoSense, our objective is to keep seniors safe and provide peace of mind for families. So I think it's no secret the world's getting older. And I think the main thing that we see is not just that it's getting older, but it's also that the senior living facility ecosystem is probably not sufficient enough to support most of the seniors. In fact, I think they only cover a very small percentage. Most of the people are living at home. So the home space and the aging in place situation is something that we all have to kind of think about, how to solve that in a very safe and efficient manner. Um, Caring for seniors at home is becoming, critical. Unalerted falls are the really leading cause of injury and death for older adults. In Canada, it's about 8,000 to 10,000 a year, which is significant, right? So I know this because when we built the company, I personally lost two grandparents from falls, and I actually had another one fall about a year ago. So she's still with us, but she's obviously her lifestyle has changed. So when we're thinking about the home, like what solutions are available? What are people using, right? Cameras, I think generally people don't feel comfortable with cameras in the bedroom or bathroom. And that's a really like critical area that you need to cover, right? So cameras are having some challenges. Microphones, generally people are rejecting that as well. And wearables, I think, is more popular than some of the camera microphone stuff we see. The really concerning thing with the wearables is not the rejection rate, but it's actually that when people fall, only about 20% press the emergency button within the first 12 hours. And you're wondering why? Like why are they on the ground not pressing the panic buttons? Because they don't want to go to a home. So most people don't want to go to a home. If they press a wearable or press a panic button, they feel like that's a solution. So a lot of them feel like they don't want to do that. So what you're left with is traditional sensing, like, radar sensing, Wi-Fi sensing. The issue there is just traditionally been accuracy, like a lot of false positives, a lot of false alarms, missed falls, because it's a very hard thing to do from a radar perspective. So in a nutshell, that's what we've really kind of been able to solve at PontoSense. I think for a lot of our deployments today, we are nationally launched with the leading home care agencies in North America. When I say only viable solution, it's a very big claim, but I think apart from cameras, from a wireless perspective, we're really the only ones that's accurate enough to be deployed in homes. Um, and really, I think this is kind of where we talk about care. I think there's a lot of comments that have been made about care and being proactive, preventative, those kind of words that start with P, right? That we want to do. And I think that's kind of what we see as well, is that people don't just want to have a good solution. They also want to know, hey, I want to know if things are not going well, despite the fact that grandma doesn't have an accident yet. Right. So those are some things that we've been able to capture with what we've been able to do at Ponto Sense. And just to dive a little bit deep in technology, because I'm a little bit of a nerd, I like I like doing it. We are, in our nutshell, a deep tech company. So we innovated at every single level of that architecture, including building the semiconductors for some of the biggest companies in the world. We're able to capture data accurately with about 1,000 times better than market solutions, which is about 30 decibels. So our core technology captures really, really small movements. We're talking about 0.2 millimeters, smaller than a heartbeat out of the chest. So there's a lot of things that we can do with that technology going forward as well. But I think accuracy is really important for this type of thing. So yeah, just a little bit more here about our positioning. So move beyond that, like with that technology, what are we able to really do? Well, I think, presence, bed exits, zoning, movements. We can know when mom goes to bed, when she wakes up, when she gets to the medicine area, when she, goes to the bathtub and all those different things. I think those are all really important things. Along with that, you have the weekly reporting and all those other things that you want to track as well. You do want to have full clarity to the home, and that's what we're able to provide today with our solution. Just a little bit more about the company. Many of you guys may be hearing Ponto Sense for the first time. We're headquartered in Waterloo, Ontario, but we do have offices around the world. We have production sites in 5 different countries, so we're able to supply to different places in the world. Today, we're active in 22 countries, and we are really actively focused on growing our presence in North America, US and Canada, specifically. So I want to end the presentation, talk a little bit about Canada, right? Because that's where we are, that's what we care about. What are things that makes Canada unique? I think the main thing that stood out to me was that 40% of everyone over the age of 15 in Canada is a caregiver. That's bonkers. That's like 2 in 5, right? Are caregivers to a senior. And then most seniors don't want to leave their home. And also the facility infrastructure system isn't necessarily built up to be able to support that either, right? There's 5 million people over 75 and only about 200,000 beds. So the solution isn't to build more beds, right? The solution is probably to figure out how we can keep people safe in homes. And really kind of how we do that and what we really think about is really 3 things. Number one is you have to keep them safe. I think it's like driving a car without an airbag, right? So safety is really the number one priority. Get everybody safe, and that means fall detection. But while you're doing that, you're dealing with a lot of people's families and things like that, where privacy and dignity is really, really important. I think like cameras and wearables, they have their advantages, but they also have a lot of challenges. And those are the things that we really think about is they want to be safe in their homes, but they also want to do it in a very private and dignified way. And the last thing is, again, not just focusing on not focusing just on fault prevention or fault detection, but how do you predict things, right? We have cases where we see people mobility declines over weeks, right? And we can see that from our data, but those are things that's also important. Just because they're not falling doesn't mean they're not doing well, right? Or they're doing well. So a lot of those type of things is a layer that we really take a look at our company to make sure that people are safe going forward. So the last information here I have is if anybody wants to reach out to us, and I'm going to throw this offer out to everybody here, is that if you want something for your own families or some business collaboration, please reach out to info@pontosense.com. I check that email box far more frequently than I should. So I'll be making sure that we can respond to you, but we really want to keep people safe and this is the way to do it. So thanks for your time today.
Thanks, Alex. A really interesting technology. So a few questions have come into the chat box, or into the Q&A box, I should say. If anybody else has questions, post them in there. So first, Brenda was asking, is this service available in other provinces like BC, and is it covered in rural areas?
Yeah, rural areas is actually a really big initiative that we do, and part of the things that we actually do with Age Well is to target rural areas. I think people have, I'm Ontario, so I used to cover Ontario references, but like people living in like Sudbury or Timmins, it's available in 22 countries and all across Canada as well. So, yeah, if you guys have a parent or something or a grandparent, like reach out to us and we'll make sure you get set up with something.
Right. The next question is from Doug. Does your solution work with Google, Samsung, and other APIs?
We don't work with existing solutions like Google or Samsung. We do have our own API that we connect to a lot of home care agencies and different, systems, but we currently don't work through those companies. We also think that internally, we think that a lot of the data going through a Google or Samsung may not be totally private. So we feel a little bit uncomfortable working with them in those capacities.
Great, thank you. All right, so I'll invite all of the panelists to turn their videos back on. So we'll have a general Q&A for the last 10 minutes or so before we wrap up. Maybe I'll, another question came in. So maybe I'll start with a question I feel like maybe everybody might have some thoughts on, is from Nathan. Do you see an emerging policy gap between independent aging in place supports and institutional care, particularly for seniors who cannot afford traditional retirement homes, but still require some level of daily support? So I feel like maybe everybody has some thoughts related to that, related to their work. So anyone want to jump in first?
Yeah, maybe I can give it a go, and Carol, you can support me, because I was thinking about the question, Carol, that you were responding around the sort of the age threshold, but what is considered older age among the rooming house population, and the reality that perhaps most of these places are meant to be more transitional type housing or short stay housing, that once they're in a more stable place where they have the financial means that they can move to a better place. But we know that retirement homes traditionally are very financially prohibitive, that you have to pay rents in the realm of maybe 2,000 to up to 5,000 a month, and where we know that a lot of this population is on social assistance, they have low incomes, that becomes out of reach. So what ends up happening is that places like rooming houses become like the de facto place to age. But as Carol mentioned, they're not places designed with the intention for people to age. So when we're talking about climbing stairs, and then to Alex's point about falls being a major issue, there is a huge gap because no one's really questioning, I guess, or there's not enough talk about how do we make aging in the right place a equitable access to everyone regardless of their income.
Yeah, thanks for, yeah, I can just add to that, say like, yes, for sure. And like I said, we are seeing a lot more seniors in these places. And I think also the reality is a lot of seniors are losing their housing as well. This is what I've seen, I'm hearing as well, just because of the law. I think it's like after 2020 a build, then they can increase their rents. So a lot of our seniors are losing their housing because they can't afford the rents anymore. So I'm not sure where people are going in terms of, and that was one of my thoughts too. Like I wonder what the cost is for this Ponto Sense. Sounds like a great program, but again, like it's probably going to be for people who have access and funding, right? But what about those who don't, right? Will there
So
be, yeah.
So we're $40 a month. Just to put that in perspective for everybody. But your point there is correct. I think I think the other question is what is an acceptable baseline level of care for individuals, right? I think what Carol, you guys are doing is I think fantastic, right? To put the people in need in terms of like, housing. Uh, but yeah,
Yeah,
we're 40.
but it's true though, like even some of our seniors like that need supportive housing, there's no spaces for them, right? This is a problem. Like the supportive housing realm, I think there's a huge need for supportive housing, but there's just a lack. Like the government haven't, they haven't built anything since the late 70s, right? So there's nothing, and it's all, and unfortunately hospitals are becoming overloaded, and like it's not great out there. Yeah. Sorry to be so pessimistic, but this is the reality that we're living in. The costs are, increasing. So it's really tough. I think it's really hard for people, and I think it's scary for seniors too, especially on these fixed incomes, right? And I'm sure some of them are supporting their children. Like that's what my parents are doing. My parents are seniors. They're still, luckily I'm able to get some support for them, but not everyone's able to do that, right? So I think it's really different. But I think, yeah, I'm not sure if the government is also looking at sort of, creating different programs like these that can be subsidized, right, for seniors.
Yeah, it's the realities. It's important to
Yeah,
address that. Yeah.
And I think just to add to that as well, like overall, all of this stress and the burden is being shouldered by the families who are trying to support their loved ones as they try to age in the place where they choose to. And it's being able to support those choices that we want to make in order to enable these older adults to live with dignity in the place where they choose to.
I
Yeah.
agree. I think it's becoming harder for families, but that's why we think we need to look at our governments to be like, what are we going to do for our populations that are becoming more seniors, right? And perhaps,
Yeah. Yeah, it's tricky to figure it all out. This is another question that may apply to most of the presentations today. From Murray, believing in patient engagement, what role can the individual play through self-assessment with your projects, or what do you see how the individual is involved?
I think, at least from our perspective, if we can kind of speak in terms of caregivers, especially informal caregivers, I think we sometimes caregivers might kind of sector management of different kind of clinical concerns or realities into something that they can't handle, or they have to handle all by themselves. I think that if we can possibly just help these caregivers kind of understand that there are resources available, and that you actually kind of hold the knowledge to structure this management better, and to make it easier for yourself and for the person that you're caring for. Like, I think just a better reality is possible for home care, especially in just supporting persons with dementia and aging at home. And so, yeah, and there was actually another question that I had the pleasure to answer by text, but sorry, in the Q&A box, which was asking about sorry, yeah, just possibly the subjectivity of caregiver burnout as well. And so there's maybe some level of concern about, self-reporting and how that's maybe not super reliable. But it still kind of surfaces that knowledge, which is critical to care within the home, and also to caring for oneself, in a way, because even if you have all these strategies and different solutions available, if you can't care for yourself and manage yourself, and have an awareness of like where you are as a caregiver, then none of that might work. And so I hope that adds some value.
Thank you, Shua. Yeah. Any other thoughts on kind of self-management and how those relate to age tech?
I was just add one point from our view is like it really it's a mutual conversation. I think a lot of times when families want to put something in that, keeps, parents safe, but the parents have to buy in as well. And I think like this whole thing with aging with dignity is that a lot of times in our society, I think that, seniors don't get the dignity and the privacy that they deserve. And families are like, I'm putting this in regardless of what you think. And it's just like, why do that? Like I think it's their home, right? They want to age well in their home. So I think um, the communication, the buy-in from all parties is really important in many cases with technology.
Yeah, all being on the same team, and that will probably be a more effective implementation. Okay, great. Well, thank you everybody for joining us today. Thank you to the presenters. We'll wrap up our session here today, and I hope you join us for our next sessions. Take care, everybody. Enjoy the rest of your Monday.